There we go. So we were talking about drug elimination, um, and we were talking about 4 to 5 half-lives before the drug is um, released. And that's what this chart was kind of explaining. If there's a long half-life, a loading dose can be given. A loading dose is not used with every medication, but sometimes we'll give a higher initial dose, and that's what is meant by a loading dose, to kind of reach plasma levels, and then the drug interval, how often we're giving the drug, is really important in keeping that drug in its steady state based on its half-life and how it's eliminated. There is another action here, is the plasma concentration of the drug versus time. So when a concentration rises until it's eliminated, that's what's kind of known as when do we reach peak plasma level. And really what we're talking about is the concentration has to rise before the drug is being eliminated. If we look at this chart, there's a lot of extra notes under here, but I'm not going to read each one here. So if we're talking time in hours, this drug might reach peak plasma level at an hour and a half. It starts to wean off. But then if we talk about, toxic concentration, minimum effective concentration, the time over hours, all this is explaining is understanding half-life and understanding drug interval is designed to stay in therapeutic range, keep that drug at plasma levels that will achieve the effect of the drug. And the clinical application of that, like I explained yesterday, is making sure the client's knowing you have to give this every 12 hours versus once a day, really can't alter that interval, because that interval is designed for a specific drug to maintain a therapeutic level. So, and that's kind of where a technician comes in, is like I explained to the owner, yeah, you don't want to alter this timing. Okay. So how they work is, their effect on cellular functions at their target tissue. Like if we're talking about, antibiotics, which, are working actually to slow the growth of bacteria. If we're talking about laxatives, and, they're increasing the peristaltic action. So, when you give a laxative, the target tissue, obviously the intestine, what is the goal? Increase motility. Antibiotics, to minimize the growth of bacteria, actually prevent an overgrowth, can also alter chemical compositions. When we talk about we mentioned the antacids changing the pH of the stomach. And when we talk about, and gosh, I wish these slides, sorry about that, is there also their affinity for a tissue component. And remember, we talked about drugs can be lipophilic, hydrophilic, and the way they're designed is to target a certain tissue. We talked about gas anesthesia having, a high affinity for fat, but the brain being, the neurons and absorbing into the brain because of the fatty tissue, it's designed for that target tissue to create the uptake, to create the effect of the drug that we want. And then certain drugs will bond to a cell. You remember hearing about receptors. And so certain drugs, when they're given, obviously they're not going to cause an effect, and they're going to wait till they find a receptor. So when we talk about receptors, these glycoproteins on the cell, remember I kind of talked about a ball and a glove. If you've got a glove and, that ball, if we talk about the receptor and the ball being, yes, except that I'm in the display phase. Yes. And so I need to go, and I'm going to keep going, but yes, I got to go in and change that transition. But I've been having some trouble with PowerPoint, so I didn't want to mess with it, but yes. So if you talk about, we talk about receptors on the cell, can be within the cell. Um, there's a certain amount of receptors, and not every cell has a receptor for every compound. So if we talk about, for example, when I talk about the opioids, and we talked about opioid receptors, and, but then you've got alpha 2 drugs, and they're going to go to certain receptors. So, that's why a drug doesn't have an effect on everything in the body. It's designed to work at its specific receptor. For example, if I go under here, if you look at the gray box underneath, that's going to be better. When we talk about an agonist is going to bind to a cell and cause an action. It triggers a response once it binds. So like morphine, for example, is a mu agonist. So when morphine is given, it goes to the mu receptors, it binds, and it's going to cause that effect. And remember, in anesthesia, I gave you guys that chart. I gave you the mu, kappa receptors, and what drugs agonize which receptors. Now, those receptors cause an effect, like mu causes euphoria. And so the good, when the drug is given and bind, and you've got the euphoria feeling, but also respiratory depression, so there's the good and bad. Sometimes when you deal with drugs, and you give a drug and it can cause some good things and cause some bad things. So a strong agonist, it's going to cause a maximum effect. It can be a weak agonist, but then there's a partial agonist, and it creates an effect only partially. If I talk about, when we talked about buprenorphine being a partial agonist, it doesn't go to each opioid receptor and cause that effect. And if you remember when we talked about butorphanol being an agonist-antagonist, so when you give butorphanol, it goes to certain receptors and agonizes that receptor, and it binds, and it's an antagonist at certain receptors. So you have to think of it in those terms. Understanding, the first part of understanding that is what happens at that receptor. What is that receptor responsible for? Is kind of, then you understand this concept a little bit better. Now, if you talk about giving an antagonist, then, we're talking about reversing an effect. If a drug agonizes, when you give the antagonist, we expect reversal of the effects of the initial drug, which is the agonist. So if we look at, let me get this next slide, you can look at the picture. So it can be, if it agonizes at certain receptors, an antagonist is going to bind and change that receptor, almost blocking it. Probably one of the more common examples of this is what you guys are dealing with now. You give dexdomitor, and it is an alpha 2 agonist, causes the sedation, the bradycardia, things like that. And then when you want to reverse the animal, when you give the antagonist, it's going to go to those alpha 2 receptors, and it's going to kind of block them, but it essentially removes those effects. So they become awake, and heart rate might come up, they're breathing a little bit more. So not every drug has an whoops, sorry about that. Sorry, you guys. Not every drug has an antagonist. So we talk about alpha 2s. Diazepam has an antagonist. And obviously the opioids. Narcan or naloxone is a pure antagonist. So there are ways to reverse certain drugs and reverse those effects. And again, going to those receptors. Let me pull up the other PowerPoint here. Let me close this one, sorry. And, whoops. Okay, hold on 2 seconds. Actually, I should Sorry, I don't know why this closed. Hang on, guys. Sorry, the computer's having a lot of fun. Now, PowerPoint. Okay, I think I have it on non-transition, so hopefully it's not going to do that. Okay, so again, pharmacology is so broad. You know, we're going to just kind of hit on pain as far as types of pain. And wow, I do not know why it's cutting off part of the slide. Huh. Okay, so we have to talk about visceral, somatic, and neuropathic as forms of pain. So if we, sorry. So if you have visceral, and you always think of visceral and organ. So if we're talking about organ injury and something within the body cavity, somatic, and soma is body. So somatic pain, you know, musculoskeletal body surface, you know, so I want to say like maybe superficial pain versus, and sometimes you hear about superficial and deep, but you have your deeper internal pain and then musculoskeletal surface in pain. And then neuropathic is, you know, if we have like a spinal cord nerve injury type of pain. So kind of understanding the injury and understanding where it's coming from. Sometimes it's hard. And again, you should be able to know the clinical signs of pain. Sometimes a change in respiratory pattern, breathing more often, vocalizing, whimpering. Sometimes they can bite at an area. Sometimes you'll see them turn around and maybe they're biting towards their hip or biting towards an area on the leg. A change in personality also as well. You know, sometimes an owner might complain, you know, they're not interacting with the family, or they don't like me to pet them here, or they're kind of like hiding in the corner. And decreased activity and a reluctance to move, especially if you have a dog that is very active. You know, and cats, I've always said, you know, are a little different. One thing in a cat, you know, that can be key is a lack of grooming or hiding in areas that they don't. I mean, I think all of us know, like my cat has places that he hangs out. There's predictable places I can find my cat. And, you know, when they're not in those certain areas or they look unkept, especially if you have a cat that's normally fastidious groomer, you know, they're very clean and they're looking a little rough. Obviously, sometimes a diminished appetite or, you know, and again, lack of appetite can mean a lot of things, but these can all, you know, if they're with another one of these signs, there might be some pain, change in posture, weight loss. Oh, go ahead. Sorry. I don't, why is this? There we go. Okay. Apologize. Let me go back. Okay, so the physiology of pain is, you know, if you talk about nociception, which is detected, you know, detected by the nervous system, where it can, you know, we're talking about an actual injury or the potential for, you know. I've talked about this in anatomy too, and sometimes in anesthesia where, you know, in my example, ooh, I think I was going to hurt my hand, I withdraw it. So, you know, physiologic pain warns you if you actually touch something, but it can be sometimes no outward injury is seen. And then pathologic pain is actually following the actual injury. So if we talk about, you know, we did this, and some of this is in anesthesia, we talked about you know, acute versus chronic pain. You know, obviously when they have surgery or just pulled all those teeth, you know, that's acute. Now, was that dog having pain before? But, you know, arthritis, cancer, chronic conditions is a form of chronic pain. I think I'm just going to mute people because I'm hearing background sounds. Now, so you've got the classification of pain based on, you know, the type of pain that we see. Is it visceral somatic? Is it severe? Is it superficial? We've also talked about this before, you know, the pain pathway. But basically you have a noxious stimulus, so something is detected. A signal is sent through a peripheral nerve. There is transmission where they send this cord or send it to the spinal cord, the signal is sent. Modulation is where it can be amplified or suppressed. So remember, when the signal gets there, the body can decide what type of response are they going to have to the pain. And then the perception is when it is actually recognized. Now, under this gray box, and again, I always tell you guys, open this in the notes page so you can see this. You can see the drugs that, remember when I talked about multimodal analgesia? You know, we don't typically give just one pain medication. Sometimes, you know, like our orthopedic patients at VCA, they went home on tramadol, gabapentin, and maybe Rimadyl, you know, and some clients might get apprehensive, like, oh my God, I'm giving my dog all these drugs. And you can explain, you know, we're trying to treat pain at different pathways, because if this is the pathway to pain being recognized, what drugs can, you know, kind of interrupt or treat pain at that level. So, you know, sometimes you do use one medication, but sometimes we can give multiple medications. Like I've said before, when you give a local anesthetic, that interrupts transduction. Well, if we block or give a nerve block, and then that signal cannot be sent, there's not going to be transmission and modulation. There's not going to be perception of that pain. So, you know, different drugs that we can give, and, you know, non-steroidals, steroids, opioids, local anesthetics, alpha-2s, they all work in different areas. Now look at step 3, modulation. Impulses are amplified or suppressed. So ketamine. Now ketamine, primarily we give it as part of our induction protocol, part of Kitty Magic. Ketamine is also used in our morphine, lidocaine, ketamine, CRI that we can give for pain. And it's, again, it's altering that modulation, which then again, if we alter modulation, do we get to perception? So again, treating different levels of pain at different pathways. Talk about the consequences of untreated pain. And again, catabolism and wasting, you know, that's not something that's seen like, okay, the next day after surgery, we didn't treat them and they're wasting away. But, you know, if you've got chronic pain and it has not been treated for a period of time, immunosuppression, inflammation, you know, one thing that I stress, and especially with you guys in anesthesia, is you have a higher anesthetic risk because you're going to have to run more anesthesia. If, you know, now, so if you give some dextrose butorphanol, you've given some pre-analgesia before the pain has started, but you can take any animal out of the kennel, throw a mask on their face, and do something to it, but that has no analgesia. And then when pain does kick in, and you know, the amount of gas you would have to use is so much higher. But if you gave them a pre-med and an induction, you know, which is all that, what we said, balanced anesthesia, the goal is that we can use less drug. You know, I'm doing inhalants with anesthesia students now, and I'm talking about max sparing. I mean, the whole reason that you use the pre-meds and induction is to run less MAC. You know, gas anesthesia is not innocuous. It's not benign. You know, everybody thinks, oh, it's safe. They just exhale it off. There's a lot of side effects that come with gas anesthesia. So if you can run a lower amount by giving other agents, it's actually safer. for your patient. You know, they all have side effects, and we want to minimize that as much as possible. You remember the two forms of hyperalgesia, primary versus secondary, which, you know, this is kind of related to, have you treated the pain? When they first initially, you know, if there's pain in an area and the nerves are firing, they might be sensitive. You know, algesia is feeling pain. Hyperalgesia is a heightened state of that. The area can be sensitive to non-noxious stimulus. Well, what's a non-noxious stimulus? Noxious is like to cause injury or pain. If I go to pet a dog, that's not painful. But if a dog is sensitive in that area, not what I'm doing is not painful, but they're kind of in a hyperalgesic state. And what it starts with that, if you continue to not treat the pain, it goes to a secondary type of hypersensitivity. And this is what we talk about wind up, is wind up pain. Now, you could touch a dog on its head, maybe the leg was injured. You're far away from the site of injury, but because those nerves have been firing and the dog has been feeling pain, sometimes they become overall hyper or secondary hyperalgesia. And so they are hyperexcitable. So, you know, a very non-noxious stimulus of just touching the dog, they may react to it because, again, they're in this hyper state. So when we talk about justifying, and this is type of board exams that these are the, you know, why give preemptive analgesia? Why do we treat pain? To prevent windup, to prevent this secondary hyperalgesia. And I've told you guys before, you know, if you start with a good pre-med, and, you know, when we have patients in the ICU at VCA and they've had a big surgery, they're on consistent pain meds for 24 hours. At Purdue, we gave morphine every 4 hours, regardless. It wasn't like, oh, if they're painful, call us. I mean, that's kind of older thinking. You know, we knew that it's better to give morphine at a consistent interval. And then we achieve, and it starts with a good pre-med. If you wait until the animal is in this this secondary state, then you have to use a much higher dose to kind of overcome that windup. And that's when we talk about loading dose and giving a high dose of like a morphine or a hydro, overcome windup. So if you can start low and give it consistently, it's going to be better for your patient and control the pain. Now, I talked about what are like signs. If I looked at an animal at my home, or, you know, I always try to put you guys in the spot of like, you could be in an ICU monitoring patients overnight. So there's going to be behavioral changes, postural changes, eating changes that you might see. But what physiologically is happening in the body? And this is not stuff you see on the outside, inside. So first of all, increase in ACTH release. And again, ACTH, adrenocorticotropic hormone, which stimulates the adrenal cortex, and then we release cortisol in times of stress. So we get elevated cortisol, norepinephrine, and epinephrine. Well, those are all things that are released in, you know, our fight and flight. Increased heart rate, increased blood pressure. Anytime you increase the heart rate, you increase myocardial work, increases myocardial oxygen consumption, consumes insulin. So it can decrease it, you know, because we're mobilizing glucose in times of stress. What else happens? Well, we get the vasoconstriction, myocardial oxygen consumption. That's a very fancy word to say you have a heart muscle. If you make it work harder, it is a muscle. It needs more oxygen. Well, everyday happy, healthy patients, probably not a problem. They can get oxygen, they're breathing, muscles are fine. But we worry about taxing, you know, the heart and those patients that may not be 100% normal. So again, it's a cascade of events. And then when we talk about the inflammatory pathway, which is part of pain, you know, you've got inflammation and that starts healing. Okay, so you do want inflammation. But when the skin, like a basic surgical incision, you have a nice sharp blade, cuts the skin, even edges, but you've disrupted the skin. You've just cut into the muscle, and then it's going to start to heal. Now, you close the surgical incision, but what happens is you get vascular changes because the vessels near the area of injury, they're going to dilate. They're going to bring clotting factors. They're going to bring, white blood cells. They're going to bring, there's an increase of blood flow to that area. When that happens, you do release chemicals, potentially harmful agents. It's kind of the initial healing. It has to start with inflammation, and there are the steps. But again, you don't want it to continue. That's what we worry about, was this continued. So here's some signs of inflammation. Obviously, when you talk about pain to the area, sometimes heat, the area will feel more warm. You'll get redness because, again, tissue hormones, remember prostaglandins, histamine, they dilate those vessels, they bring blood to the area, so it's going to look a little more red. And then you've got swelling initially. Now, it may not be, all kinds of injuries swell differently, but there can be. You've got increased tissue permeability, so everything's rushing to this area of injury, potentially decreased range of motion from the injury. When an area is swollen, it doesn't bend or move as well. And if it doesn't move as well, that causes injury. So when you have pain, heat, redness, and swelling, this is the initial phase of starting to repair the tissue to make it normal. There's beneficial, but you worry about these chemical mediators, prostaglandins, the leukotrienes, cytokines, and initially they're released to bring certain things to that area, but that can also start to cause, the swelling to get worse. If you talk about that initial, what are the chemicals? What are they doing? So the phospholipids are broken down. Cyclooxygenase and lipooxygenase break down the acids, the prostaglandins, that causes the inflammation. You get the vascular changes because now the vasculature in that area is more permeable. You get the increased blood flow, plasma proteins, vasodilation, redness, and heat. So this is all that initial phase: injury, lipooxygenase, prostaglandins, thromboxane. So when you use a class of drugs, which we've talked about, anti-inflammatories, then this is like a double-edged sword. You do need inflammation to initiate the healing. So it's useful, protective response, but then we get to a point where we have to reduce, because inflammation does produce pain. So, you have to have some healing, but we have to also minimize some of the painful effects that come from that. So I want to say, when we talk about we want to control inflammation because a lot of pain comes from it, there's two main categories of drug that do this. Now, you have steroidal anti-inflammatories, which are steroids like dexamethasone, prednisone, okay? And then you have the non-steroidal, which are the NSAIDs, non-steroidal anti-inflammatories. Now, a third category to think of is the antihistamines, okay? But so like, for example, a dog gets stung by a bee, and, there's obviously, sometimes there's just the redness and you get a bump in the area of the bee sting. Now, sometimes you get, if an animal's allergic, and you get a more systemic reaction. Sometimes those dogs come in and if they're in a more of an anaphylactic type reaction, they're probably going to get like dexamethasone, Dex-SP. It's a steroid we can give IV. We usually use that in immediate, like vaccine reactions, allergic reactions. But you can also give Benadryl if it's kind of a minimal reaction, because generally when there's an allergic reaction, we know that histamine is released, which comes, you got your mast cells, they release histamine, they respond to those allergies. But again, that's kind of for the more local reactions. But if you have if you have a massive anaphylactic, you're probably potentially getting an antihistamine on top of a steroid. The first group is the steroidal anti-inflammatories. And these are hormones produced. You have, remember we talked about the adrenal cortex. You got the outer part of the adrenal gland. Remember, the adrenal cortex is a cortex and a medulla, one gland, two parts. Cortex produces hormones, medulla produces hormones. The cortex produces a group of drugs called the glucocorticoids. So if we go down here, a hormone, remember, this is a little endocrine review, is a chemical messenger, and it's signaling something to happen in the body. It's mediating an effect of something. So it's going to another part of the ovary to regulate organ activity. Remember, all the hormones keep the body in homeostasis, okay? And remember, I always said there's a hormone, there's a target of that hormone, and it causes an effect in response to something. So when we talk about the glucocorticoids and the mineral corticoids, which are produced by the adrenal cortex, and again, those occur naturally in the body. The glucocorticoids have an anti-inflammatory effect, okay? They release cortisol, which is normally times of stress. Injury and pain can cause stress, right? So we get a release of cortisol. Aldosterone is a mineral corticoid, and that usually, think about mineral corticoids affect minerals, sodium, potassium, and I think about water balance. When I hear minerals, water balance, electrolyte balance, sodium, potassium. They do not affect, per se, inflammation, but that water balance is when we're going to kind of get into, blood pressure, fluid balance, hydration, things like that. But the glucocorticoids do have an anti-inflammatory effect, and cortisol is the main glucocorticoid. That's what happens in the body naturally, but I'm talking about categories of drugs. So again, remember, for things that happen in the body, there's pharmacologic things that can mimic what naturally happens. So when we give glucocorticoids, why do we give them? Well, we reduce inflammation, we reduce pruritus, which is itching. You get reduced scarring by delaying the wound healing, and hopefully reduce tissue damage. So that all sounds wonderful and great. But the problem is there's always the downside. You also delay wound healing. So I will tell you, a very common thing when you guys take a history is the animal on prednisone. Prednisone is a glucocorticoid, okay? And a lot of animals are on pred for skin lesions, and and sometimes people just give it. They come in for surgery for another reason. It could cause delayed healing. Sometimes the doctor might say, okay, we're going to stop the pred before surgery. It alters our drug plan, potentially our surgery plan, but you get delayed healing. You can get GI ulceration and potential bleeding. That's always a side effect when we use steroids, is GI ulcers. Corneal ulceration, abortion in some species. If we think about the glucocorticoids that are synthetic, meaning the drug form, the pharmacologic form, they have a greater effects than obviously the ones that are produced in the body. The way we categorize the glucocorticoids is their duration of activity. I mean, you can have short acting, intermediate, and long acting. And there's so many different formulations. So for example, prednisone comes in a tablet form. There's a liquid form. It can be added to eye medications or dexamethasone. And this is a tip, and I always try to give you guys clinical tips. A lot of your eye medications, now we had an ophthalmology department at VCA, so of course our eye medications, we had a central pharmacy for the whole hospital. Sometimes my boss would be like, we're in oncology, she'd be like, oh, we're gonna put this dog on some antibiotics for their eyes. But there's antibiotics with just antibiotics, and then there's antibiotic eye ointment with dexamethasone added. And it's very important. You don't want to give with the steroid form. So be very careful when you're dealing sometimes with you know, just like I said, that's the most common thing that comes in my head, is that eye medications sometimes can add a steroid in, but then they usually have just the antibiotic form. And there's definitely times they're not the same. There's times where you're just going to use the antibiotic eye ointment, and sometimes they do want a steroid, but the steroid can cause damage in certain eye conditions. So you have to be aware. Sometimes these are added to other, you know, medications, topical medications, tablets. You know, you can give them via injection, you know, oral agents. So here are different corticosteroids. Now, there's a lot on here. The ones that I would say are the most common that you're going to deal with, dexamethasone, and then there's Dex-SP, dexamethasone, sodium phosphate, and just dexamethasone. And sometimes you're going to use one versus the other. And you have hydrocortisone. Now, hydrocortisone, I usually think about, you know, that does come in a tablet, but a lot of times hydrocortisone is in topical. You think about, you know, if you ever had poison ivy, or you have some bad mosquito bites, you go get a tube of hydrocortisone cream to put on your skin. So a lot of times I think about hydrocortisone as more in like our topical preparations. Methylprednisone is Depomedrol, and that's injectable, but then you guys will use a lot of prednisone and prednisolone. Now, prednisone and prednisolone. Yes, James, so, or JC, sorry, yes. So let me put it that way. It's the same drug, but if you look on the tube, when you get it, there's different percentages of hydrocortisone. So that would be the difference, is some, you know, there, you know, if you look and read the back of the tube, it would tell you like what percentage of hydrocortisone, you know, so it's the same. No, I think it comes as high as like 10%, like you get the extra strength. No, when you're using it on the skin, and when you hear about the side effects of steroids, and then you're like, oh my gosh, I'm using this cream. I mean, but the amount that does get absorbed in the bloodstream, you know, not the same as if you would be taking like tablet form or injectable form, because by then, you know, it's diffused through the membranes. You're not absorbing, if that makes sense. So we keep some hydrocortisone. I mean, sometimes I get weird, like mosquito bites, and it gets crazy, itchy. You know, it's always hard. You know, I think you guys realize this. We don't use a ton of topical creams and ointments like that on animals. You know, number one, there's fur. And number two, with the grooming, it does make it challenging sometimes to use these agents, because they need to stay on for at least a half an hour for it to kind of kick in and cause the effect. We used a lot of topical ointment when I did radiation oncology, thermal burns from obviously the treatment. And I always told owners, you know, based on what Dr. Reckner wanted me to say, but she's like, if you can at least ensure that it's stayed on for a half an hour, they've gotten the benefit of the topical. If they lick it off after that, you know, it's challenging. So, but I do want you to know there is a difference between prednisolone and prednisone. So this actually should say prednisone and prednisolone. So when you're filling that, again, a lot of clinics put all their pred, and it comes in different milligrams and different formulations. They might put it in one spot. You might grab one or the other. So prednisolone, I've seen it used more in cats, prednisone in dogs. Triamcinolone is another one you might use. The common one that we use is Vetalog. Yeah, I don't know, JC. I'd have to look at that. It's probably a form of a cortisone. I'd have to look at that. You might hear of Vetalog. We had Vetalog. It was a common injectable we would use. It was on like skin patients. It's a little bit longer acting. Now, when we give glucocorticoids, this can be, now there is a difference, I will tell you. Sometimes the dog gets a rash, we give them a week of pred. Sometimes I've heard of dogs being on pred for 2 years for chronic skin conditions. So, you know, when you're using it for a short course, you're not going to see as much of the side effects. But there's a lot of cases where sometimes animals are just put on it for a longer amount of time. The longer they are on, you know, glucocorticoids, they start to develop these signs. Now, I'm going to start, if you see this is light blue and it goes around here, it gets darker. Initially, they're very PUPD, okay? It makes them thirsty. They tend to drink a lot. They pee a lot. That's probably the number one thing I tell owners when I said send home a steroid. I'm like, they're going to drink a lot. They need to go out frequently. The only time I said my dog has had accidents in the house, my old dog, was when he had his meningitis and he was on high dose prednisone. So they drink and pee, and they also tend to be polyphagic, and so they're very hungry. So they may eat more, eat faster, want more, and that happens after a while, and they can get suppressed healing. So again, what is a glucocorticoid doing? It's minimizing its inflammation. Well, inflammation accelerates wound healing, but again, some inflammation causes side effects that we want to minimize. So you have to watch the wound healing. Gastric ulcers is the other thing. And I hammered this, guys, when I did your pain lecture in anesthesia, is whenever they're on these meds, or when I talked about NSAIDs, is like, how do I know the owner cannot see their stomach? How do I know my animal has a gastric ulcer? Well, probably not eating. They might go to their bowl and drool because their stomach hurts. But then we think about melena. So you might actually have vomiting. So vomiting, diarrhea, melena. But also sometimes inappetence and drooling is an early sign of an ulcer because the stomach hurts, and then, you know, they kind of feel like they want to eat, but then they're like, it's making me nauseous. So, you know, I tell owners, if you see any, you know, like all of a sudden they don't want to eat anymore, because this is a drug that should make them want to eat. So that would be kind of significant. But drooling, vomiting, diarrhea, melena, all things like that. Thinning of the skin. Now this is longer use, but their skin can actually become thinned and they can start to get muscle wasting. This is going to be the animals that are on the longer term pred. And then you can get into something that's called iatrogenic Cushing's. What does iatrogenic mean? If I throw that word in there, what does that tell you?
It's something that we caused.
Right. So animals can get natural Cushing's disease, but if it's iatrogenic, it can be initiated with long-term glucocorticoid use. So when we get the Cushing's, a lot of times when they come in, they've got the thin skin, thinning of the fur, sometimes a pot belly appearance, they're drinking and eating a lot, urinating a lot. So there's like a combination of signs. And then obviously, if we saw in the history they've been on prednisone, it's kind of like red flag, like maybe they are actual Cushingoid. On lab work, you can see lymphopenia, eosinopenia, monocytopenia. 3 of those drugs, we're talking about moderators of the immune system, minimization of those, thrombocytopenia, but you can also see a hyperglycemia. So, you know, there's a note on here that's called like a stress leukogram. So there's when you look at a leukogram, leuc meaning white, it's the representation of all the numbers of the white blood cells. So it'll give you, remember, it gives you an overall white blood cell count, but then it will tell you the individual numbers, and you might see some of this. So when we give glucocorticoids, and sorry about these slides, this is key. They're not treating the disease. Okay, so they're not treating the disease. They're kind of treating the signs of the disease. And infectious microorganisms can potentially become worse because when you give these drugs, you're kind of like calming down the immune system. You're kind of like minimizing the immune system. Well, the immune system is kind of helping in the body. If you have a kind of like a brewing infection, and then all of a sudden I minimize the immune system, that infection's like, woohoo, I'm going to take hold. So, you've got therapeutic doses, your immunity is suppressed, number one. And that's the primary immunity against fungal infections. Let me give you a perfect example. When my old dog, so I've had 2 dogs with meningitis. Ozzy was my first. He was 2 years old. When he initially got meningitis, he had a high level of eosinophils in his spinal fluid on the CSF tab. And, we know, what do eosinophils respond to? Well, typically allergies, parasitic infections, So initially, we still didn't know. We knew he had meningitis. What caused it? And there was a week where we were still waiting. I ordered what's called titers on his spinal fluid. I was like, we do fungal titers, viral, bacterial testing. Is it bacterial meningitis, viral meningitis, fungal meningitis? Well, one of the key treatments for dogs with meningitis is to put them on high dose steroids because there is inflammation in the brain. So what's the quickest way to minimize inflammation? Give them a steroid. Except that if he did have fungal meningitis, if we put him on pred, that fungal infection could blow up because the immune system is kind of trying to moderate that infection. So until we ruled out viral meningitis and fungal meningitis, they wouldn't put him on a steroid because they're like, it can make it much worse. Now, when all was said and done, he was negative for any fungal, viral, bacterial component. So it was called idiopathic, meaning we don't know why your dog got meningitis. I was like, fantastic. But then he could be put on pred, and within a day or 2, he felt fantastic. But he was on what I call immunosuppressive doses of prednisone, super, super high, because we had to they just, his immune system attacked those membranes, caused this. Like I said, I still don't know why, but he got better. But again, so what this is telling you is that the reason I was giving my dog glucocorticoids in that he had massive inflammation. But the problem is I have to watch him close because he was on such immunosuppressive doses that he is susceptible to that, other potential infections. So again, I didn't really take him anywhere or do things with him. I'm not like going to the doggy park or doggy daycare or, play with the neighbor dogs or, when you're dealing, it's just like when humans are immunosuppressed. It's like they don't have lots of visitors in the hospital and things like that. But that's what this group of drugs does is it's really suppressing the immune system. So some things to think about is you try to use, obviously topical is going to be, you're going to get less side effects naturally. And sometimes you can do alternate day dosing. A lot of times so for example, when he was on prednisone, he had to be on daily high dose. But then after about a month, he went from like 40 milligrams once a day for a month, 30 milligrams once a day for a month, 20 milligrams a day once a month, 20 milligrams every other day for a month, 10 milligrams every other day, 10 milligrams every third day. Most of the time when we prescribe steroids is we will do a walking off dose. And I don't know if anybody remembers, but what happens when an animal's getting steroids via, tablet, injection, whatever, the adrenal cortex, which usually produces these natural glucocorticoids, can take the day off because the dog is getting it via tablet. So the adrenal cortex is like, cool, I don't have to do anything. the longer the animal is on that steroid, it's not that the gland completely shrinks up, but we talk about atrophy. It's like it's not being used. But I mean, if you sat on your couch for 6 months and I said, well, go run a 10-mile marathon. Most of the people that go decide to run a marathon, they start like jogging and then they start running a mile or 2 miles and then we build up. So what happens is when you back off steroids, what we were doing with my dog, backing that dose down, gradually the adrenal cortex starts producing those glucocorticoids again. Because if you do like cold turkey, if an owner just says, forget it, I'm going to stop steroids, is then the adrenal cortex has to respond to stress. And so what happens is if this gland has not been doing anything and all of a sudden you're like, okay, it's all you now. So that is very important. And again, you guys are the ones typically going over medication instructions with the owner. I think it's very negligent, and I would never just hand an owner a bag of medication and be like, this is what the doctor wanted you to take. We'll see you in 2 weeks. And then the owner's got to go home and go through the bottles and go, what? And so I was like, this is a steroid. This is for inflammation. You want to make sure you taper the dose. You have to follow the instructions. Do not stop this medication and don't run out and call us if you do. This is an antibiotic. This is, that's good client education. That's good client care, but that's your job. Doctors aren't going in the room and going over medications. The technicians do that. So I'm very, very specific when we do this. Try also, and we're almost done here, you try to avoid long-term or continuous use. We try to do short course. It's really, well, what I should tell you is that, for example, allergies. The easy thing to do, your dog is itching. Sometimes they're like, oh, just put it on Pred and people stay on it. The Pred is masking the symptoms of the allergy. It's not treating the allergy. It's treating the symptoms. So the best course of action is to get to the bottom of, is it a food allergy? Is it an environmental allergy? Is it a flea allergy? There's a reason behind the allergy. If you give the Pred, you're just masking the symptoms of the allergy. And again, the longer they're on the Pred, you're going to get these other side effects. And then again, to prevent the iatric Addison's disease, that's what we worry about, is if we just stop giving these, we don't discontinue them. And we also worry about if they have corneal ulcers, not using them can make those worse. So let me stop there. My goal, I know you guys have the practice homework in there that you can do currently. And I think we will just continue with that. I'll try to talk about some of these. I don't think I'm going to have a separate quiz on this. I think just doing your homework in there and kind of practicing those questions, because we have to end with anesthesia and kind of finish out VT&E. Do you have any questions?